EM Rapid 2023. Myself, Dr. Naveen Mohan, Associate Professor and HOD of Emergency Medicine at AIMS Kochi. Today we'll discuss about paracetamol overdose. So, what is paracetamol? Paracetamol is basically a very good antipyretic, a mild analgesic, non-opioid, non-NSAID drug. Basically used to control fever. Okay. So, in bottle formulations, paracetamol is available. It's available in tablet forms, extended release capsule forms, solution forms, syrup forms, suspension forms, suppositories, and whatnot. So before moving into paracetamol toxicity, I would like to just mention regarding the metabolism of paracetamol. So imagine this is your stomach. Okay, this is your liver, and here is your kidney, and here is the blood vessel. Okay, so any person who consumes paracetamol will straight away go to your stomach. This is paracetamol, and it may be absorbed almost completely into the blood circulation. Okay, maybe also from the duodenum area also it will be absorbed. So once paracetamol reaches the blood circulation, it takes around 4 hours to attain a peak concentration inside your blood. Okay, it takes around 4 hours to attain a peak concentration inside your blood. But if it is consumed along with some anticholinergic drug, or if it is consumed with some opiates which delay the gastric emptying time, then probably it will take much more than that to attain a peak concentration, maybe around 6 hours or so. Okay. So once the paracetamol reaches your blood circulation, it has to be detoxified, right? So this paracetamol will be straight away taken to your liver, where this paracetamol will undergo detoxification by way of conjugation. So that process is called conjugation, the detoxification process. And most of the paracetamol will be converted to glucuronide as well as sulfate moieties, which are basically both these glucuronide as well as sulfate moieties. Both these are non-toxic products. So this paracetamol has been detoxified to non-toxic products, glucuronide and sulfate moieties, by way of conjugation. Ultimately, what happens is this non-toxic product will be excreted via your urine. But at times, what happens is this paracetamol, a small percentage of paracetamol, will be converted via an alternate pathway to a very toxic metabolite which is called as NAPK. We are basically concerned about NAPK. NAPK is N-acetyl para-benzoquinoamine. Okay, so this is a very, very toxic product because NAPK causes hepatocellular necrosis and cytolysis, and thereby it causes liver damage. Okay, so NAPK causes hepatocellular necrosis. Okay, the centrilobular necrosis basically, and cytolysis. The body's own mechanism is such that there is something else which is called as glutathione inside your body, inside your liver, which converts this NAPK to non-toxic metabolites, which are called as cysteine and mercaptopuric acid. Mercaptopuric acid. So this NAPK, which has to be thrown out of your body, will be converted to cysteine as well as mercaptopuric acid by glutathione. But what happens in paracetamol overdose is that this glutathione reserves, the glutathione reserves in your body get depleted to such an extent. If you consume too much of paracetamol, the glutathione reserves in your body, it gets depleted to such an extent that it is no more available to convert NAPK to cysteine and mercaptopuric acid. Okay. So resultantly what happens? This NAPK gets accumulated. It gets accumulated and finally it causes liver damage. So in the treatment of paracetamol poisoning, basically we give an antidote which is called as N-acetylcysteine, right? N-acetylcysteine is the antidote of paracetamol poisoning. So N-acetylcysteine is nothing but a precursor of glutathione. It's a precursor of glutathione. So basically we are giving N-acetylcysteine, the NAC, so that more of glutathione is formed. If more of glutathione is formed, then that will be able to convert NAPK to cysteine and mercaptopuric acid, which are non-toxic metabolites, and that can be excreted via the urine. Okay. So both glucuronide and sulfate moieties as well as cysteine and mercaptopuric acid can be excreted via urine. We are basically concerned about NAPK. Okay. So let's discuss about. We should one point is to be remembered is that the whole metabolism happens inside the microsomes of liver. Okay, the microsomes inside the hepatocytes. So now we'll move on to the stages of paracetamol toxicity. The stages of paracetamol toxicity. So any idea about the stages of paracetamol toxicity? Basically, there are 4 stages. Stage 1, stage 2, stage 3, and stage 4. The first stage happens within the first 24 hours after consumption of paracetamol. So it happens in the first 24 hours. The second stage happens from 24 hours till 72 hours after consumption of paracetamol. Stage 3 starts from 72 hours after consumption of paracetamol to 96 hours after consumption of paracetamol. And stage 4 starts from 96 hours after consumption of paracetamol to 5 days after consumption of paracetamol. 96 hours means what? Sorry, it is not 5 days. Sorry. It is 2 weeks. 2 weeks. Okay. So 96 hours is how much? 4 days to 2 weeks. So within the first 24 hours, when the patient is in stage 1, of paracetamol toxicity, he will present with features of nausea, anorexia, vomiting, malaise, diaphoresis. You can just remember my name, Naveen Mohan, N-A-V Mohan. Okay, and diaphoresis. In nausea, anorexia, vomiting, malaise, diaphoresis. And what about stage 2? Stage 2, the patient will have complaints of right hypochondrial pain, right hypochondrial pain, and maybe even tenderness also. Over that age, the right hypochondrial age, tenderness. All right. And what about stage 3? Stage 3 will be characterized by, this is the most worrying stage, stage 3, because this is where the mortality happens. So the patient will have jaundice, deranged liver parameters. Patient may be like having hepatic encephalopathy. Patient may be having maybe in coma, and coagulopathy may be present. Maybe having deranged INR, APT, TPT, all these things. Coagulopathy may be present, and maybe even like multi-organ failure. Multi-organ failure. And RFT may be deranged. And the basic thing is, if everything, all organs are damaged, ultimately that will lead to death. So this is the most concerning stage. The stage 3 is the most concerning stage, and we do not want the patient to go into stage 3. Okay, but suppose the patient survives stage 3. Suppose the patient survives stage 3, he'll go move on to stage 4. Stage 4 means it's a period of recovery. All right, it's a period of recovery, and that will happen over a period of 4 days to 2 weeks. Okay, so let's discuss about the lab parameters during this time. During stage 1, that means less than 24 hours, what do you expect in stage 1? LFT will be generally normal in stage 1, because patient has just got nausea, vomiting, right? Anorexia, diaphoresis. LFT will be normal. In stage 2, there will be mild alteration of LFT, but basically it starts from 24 to 72 hours. It will be AST elevation. And there will be, at times, maybe some mild metabolic acidosis will also be there. Okay. And in stage 3, that starts from 72 hours to 96 hours, that is the stage in which all the liver parameters will be deranged. So AST will be grossly elevated, ALT will be elevated, INR will be elevated, bilirubin will be elevated, maybe like phosphate will be elevated, but pH will be decreased because patient is having metabolic acidosis. So this is the most concerning stage, stage 3. And if you give N-acetylcysteine, which is the antidote of paracetamol, at the right time, patient may survive, and patient will move to stage 4, which is the recovery stage. Okay, this is the recovery stage. Okay, so let me just briefly tell you about history taking in the case of paracetamol poisoning. The basic history taking in paracetamol toxicity happens in the secondary survey. happens in the secondary survey and not in the primary survey. Primary survey, as always, just like dealing with any emergency medicine case, you'll be dealing with the A, B, C, all these things. You stabilize the patient, okay? Then move on to secondary survey, wherein you'll be asking about what? The ample history, allergies, medications, past illnesses, okay, events relating to environment, last meal, all these things you'll be asking. And in this history taking, what are you, the secondary survey after the ample, it's followed by systemic examination. As always, I hope all of you know about it. Okay. So what all things you'll be asking in an ample history. So any poisoning case, basically with what you are interested in, it is when it happened, when this poisoning happened, where it happened, why it happened, who saw it, how did it happen, all these things. Okay. So if a patient has consumed paracetamol, you should ask when it happened, the time of excessive, the time of PCM overdose, time of PCM consumption. Okay. Then how much of dose the patient has consumed, the dose, because the normal therapeutic dose will be less than 4 grams, 4 grams per day. But to call it toxicity, there are certain criteria which are mentioned in the up to date. Okay. So what is the criteria? So in children and adults, both are different. Toxic dose is different. Okay. In children, what up to date says is consumption of less than 150 mg per kg of paracetamol over a period of 24 hours is unlikely. They say it is unlikely that it will cause any PCM toxicity. In children, if the child consumes less than 150 mg per kg paracetamol over a period of 24 hours, it is unlikely that it will cause paracetamol toxicity. Okay. Whereas if the child consumes more than 250 milligrams per kilograms, it is likely that the child will develop PCM toxicity. This is the term that they have used in up to date. Okay, but what about adult? In case of adult, what up to date says is less than 7.5 to 10. If an adult consumes less than 7.5 to 10 grams of paracetamol over a period of 24 hours, then it is unlikely that the patient will develop paracetamol toxicity. But they haven't told it is not there. They have just told it is unlikely. Okay. Whereas if the adult consumes more than 12 grams, it is likely that the patient will develop paracetamol toxicity. More than 12 grams. More than 12 grams for adult and more than 250 mg per kg for children. It is likely that they will develop a paracetamol toxicity. Okay. But more than 350 mg per kg consumption, more than 350 mg per kg consumption, regardless of whether the patient is a child or an adult, he will anyway develop paracetamol toxicity. That is what is mentioned in up to date. So more than 350 mg per kg, anyway the patient is likely to develop a paracetamol uh, toxicity, severe toxicity. Okay. So I've been discussing about the history taking in paracetamol toxicity. So you have asked the time of consumption, the dose the patient has consumed, and what are the co-ingestants? The co-ingestants with paracetamol, because previously I've already mentioned that if the patient has consumed paracetamol along with some opiate or anticholinergic drug, it is likely that the gastric emptying time will be delayed. Okay, so this peak level of paracetamol, I've already mentioned, it will be around 4 hours after consumption. So once the patient has consumed some co-ingestants, which delays along with paracetamol, it is likely that the peak level of paracetamol will happen sometime later, not 4 hours. Okay, so regarding that, then you'll have to ask regarding the pattern of use. You'll have to understand whether the patient has consumed paracetamol, like straight away consumed more than the toxin, maybe more than 12 grams of paracetamol, or whether the patient has consumed paracetamol in a staggered dose pattern. Okay, so that is one the pattern you'll have to ask. Then what you have to ask is the existence of comorbidities. So what are the comorbidities of the patient? Because if the patient has got certain comorbidities, such as if the patient is some chronic alcohol consumer, chronic alcohol consumer, or if the patient is having some Gilbert's disease or something of that sort, Gilbert's disease, or if the patient is on some cytochrome P450 inducing drugs. You can just check what are the cytochrome P450 drugs in Google. Or if the patient has got a history of malnutrition, because those who are malnourished are likely to develop paracetamol toxicity even at lower doses. Okay, so these are the things which, and also whether the patient is on some anti-seizure medications. These are few of the important questions to be asked, apart from the normal questioning in any case of toxins, like who, when, where, why, how, what. All these things you'll have to ask. Apart from that, these are the major questions you'll have to ask in paracetamol toxicity, because this carries important. This is important because there is something which is called as Rumack-Matthew nomogram. Okay, a Rumack-Matthew nomogram is there. It is a graph. It is a graph which which we generally use to assess whether the patient has to be whether and understand whether the patient has to be given N-acetylcysteine or not. Okay. So as always, you any case of paracetamol toxicity, you stabilize your ABCs, do a primary survey, take an ample history. If the patient has come to you within 1 hour of consumption, if the patient has come to you within 1 hour of consumption, then as always give activated charcoal, 1 gram per kg in children, or up to a maximum of 50 grams. I hope all of you know about it. And if the patient has come with like consumed a PCM within 1 hour to 4 hours. Okay, suppose the patient has consumed paracetamol at like 2 hours back. Suppose the patient has consumed paracetamol 2 hours back. Okay, then you will have to wait for 2 more hours before drawing blood samples. Okay, so you'll have to wait till the 4th hour after consumption of paracetamol, because in this graph, this is called the Rumack-Matthew nomogram. Okay, according to this graph, this is called as Rumack-Matthew nomogram. This is the graph. This is time. Suppose the patient has, this is the point where the patient has consumed paracetamol. Okay, consumed a toxic dose of paracetamol, or consumed toxic dose, and this is 4 hours. So this is 0, this is 4 hours. After 4 hours only, this graph starts, and that will extend till 24 hours. Okay, note, this starts at 4 hours and it extends till 24 hours. So if a patient comes to you with at the 2-hour period, you are not supposed to take blood samples for assessing the serum paracetamol levels, because the graph starts only at 4 hours after consumption of at 4 hours. So you wait till the patient has till the 4th hour after consumption of paracetamol, and then you take blood samples. Okay, and in your center, if paracetamol levels are available like very fast and all, then we can actually plot the serum paracetamol values on the graph. And if this is called the treatment line, this line is called the treatment line. Okay, the treatment line. If the serum paracetamol level, this is the serum paracetamol level. Okay, if it lies above this line, if it lies above this treatment line, then you will have to initiate NAC. Okay, then you will have to initiate NAC. Whereas if the serum paracetamol level is below the treatment line, then you are not supposed to initiate NAC. If it is, because it is below the treatment line, you are not supposed to initiate the NAC. But if it is above the treatment line, you initiate NAC. NAC. Also, if the patient the reports of the serum paracetamol level, if it is very much delayed, if it takes more than 8 hours after consumption of paracetamol, it's better to start on NAC early itself. Because if suppose according to a history, you suspect paracetamol toxicity based on the toxic dose and all these things, you anyway empirically you can start on N-acetyl cysteine. Okay. So this Rumack-Matthew nomogram is applicable only if the patient, in a case of single, uh, if the patient has consumed paracetamol on a single occasion. But if it is a staggered dose, or if the patient doesn't know when he has consumed paracetamol, then Rumack-Matthew nomogram is not applicable, because you don't know when the patient has consumed the toxic dose of paracetamol, right? So this is applicable only if you know the time of consumption of paracetamol. Okay. So NAC, as I've already mentioned, NAC is the precursor of glutathione, and glutathione is required for converting NAPK to non-toxic metabolites, which has to be excreted via the urine. Okay. So apart from the serum paracetamol levels, you are also supposed to draw all other lab parameters, all other values such as INR, LFT, RFT, ABG. Okay, all these things. So let me just mention about the dose of NAC. Okay. The dose of N-acetylcysteine. The dose of N-acetylcysteine. Let me just give a brief idea. So there is one protocol which is called as the 21-hour protocol. The other protocol is 72-hour protocol. The 21-hour protocol is the IV protocol. Okay, this is the intravenous protocol, whereas the 72-hour protocol is the oral protocol. This is the oral protocol. Patients who are not willing to take this IV treatment, you can straight away offer oral treatment. Okay. So, what is the IV protocol? So, according to the 21-hour IV protocol, 150 mg per kg is the initial dose. 150 mg per kg NAC is the initial dose that has to be administered over a period of 15 minutes to 1 hour. Okay, over a period of 15 minutes to 1 hour. And the dilution that has to be given in 5% dextrose. Note this. 5% dextrose, 200 ml. Okay, that is the first dose. Then the second dose is 50 mg per kg NAC, and that is given over a period of 4 hours. And then it is 100 mg per kg NAC over 16 hours. So net, if you calculate, it is 1 hour, 4 hours, 16 hours, it is 21 hours, right? It's 21 hours. So 150, 50 and 100. Okay, 150, 50 and 100. Finished over a period of 21 hours. In case of pediatrics, there is this one I forgot to mention. The 50 mg per kg NAC has to be given in 5% dextrose, but in 500 ml of 5% dextrose. The 100 mg per kg has to be given in 5% dextrose in 1000 ml. 1000 ml of 5% dextrose, 5% dextrose, 500 ml, 5% dextrose, 200 ml. Okay. This is the 21-hour IV protocol. Okay. For pediatrics also, it's almost the same thing, but only difference is that 150 mg per kg, the 150 mg per kg has to be given in 3 ml per kg of 5% dextrose, whereas the 50 mg per kg has to be given in 7 ml per kg of 5% dextrose, and the 100 mg per kg has to be given in 14 ml per kg of 5% dextrose. Okay, this is about the intravenous protocol. So let's discuss about the oral protocol. The oral protocol of NAC, the oral protocol of NAC, which is otherwise called as the 72-hour protocol. In this case, the loading dose will be 140 mg per kilogram, 140 mg per kg of NAC per oral, followed by 17 doses of NAC, and each dose will be 70 milligrams per kilogram NAC per oral. So the start dose will be 140 mg per kg, followed by 17 doses of 70 milligrams per kilogram NAC, given every 4th hour. Given 4th hour. So if you calculate, you can find that it will take around 72 hours for the protocol to get over. Okay, so this is the oral protocol. And when to stop the NAC infusion? Ideally, after 24 hours, if the patient's INR becomes less than 2, or if the LFT normalizes, then you can stop NAC infusion, stop the NAC infusion or anything. If it is oral protocol, you can just stop. But if the INR is still more than 2, even after, despite this oral or IV protocols, then you will have to continue NAC, but at a lesser rate. Lesser rate means 6.25 milligrams per kilogram per hour. Okay. And after every 12 hours, you can keep repeating every 12 hours. After every 12 hours, you can keep repeating the lab parameters, C for INR and LFT. Okay. So this is about the treatment part of paracetamol toxicity. But one major thing you'll have to understand is when to refer the patient to a liver specialist, when to refer the patient to a liver specialist. And that is decided by the King's College criteria. King's College criteria. It's available in MedCalc. Google, you can find it out. The King's College criteria for paracetamol toxicity. Okay, in that we have got few parameters. One is the pH. The patient has got pH of less than 7.3. That means patient is having metabolic acidosis, right? That is one criteria. The second criteria is INR more than 6.5. The third criteria is creatinine. Creatinine means the liver function test. Creatinine more than 3.4 milligrams per deciliter, or if the patient is in grade 3 or 4 hepatic NCOF. So these are the criteria for King's College. pH less than 7.3, INR less than 6.5, creatinine more than 3.4, grade 3 or 4 hepatic NCOF. Okay, so these are all predictors for poor prognosis in case of paracetamol overdose, and they have to be referred to a liver specialist, probably for liver transplant. Okay, refer to a liver specialist. So there are other few parameters which are also considered as poor prognostic indicator for paracetamol toxicity. One is lactate. If the lactate value is more than 3.5 millimole per liter after fluid resuscitation. Okay, after fluid resuscitation, if the lactate value is more than 3.5 millimole per liter, and that is calculated at the end of 4 hours after fluid resuscitation, or if the lactate value is more than 3 millimoles per liter after complete fluid resuscitation, which is calculated usually at the end of 12 hours. So this is about lactate. The other, this one carries poor prognosis in case of paracetamol toxicity. The other parameter is phosphate. If phosphate is more than 3.5 milligrams per deciliter, the phosphate is more than 3.75 milligrams per deciliter at 48 hours after paracetamol consumption, that is also a very poor, carries poor prognostic value in case of paracetamol toxicity. So just summarizing what I have mentioned so far, paracetamol when consumed in excess of the toxic dose which I have mentioned, that will go to your liver where the paracetamol will be metabolized to NAPK, which is the toxic metabolite causing liver damage. So to get rid of NAPK, you'll be administering NAC, N-acetylcysteine, which is a precursor of glutathione, and that will be, NAPK will be excreted via your urine. Okay. The dose I have already mentioned. The stages of toxicity I have mentioned, stage 1, stage 2, 3, 4, all these things I have mentioned. But what we are basically concerned is about the stage 3, where the mortality happens and where all the liver parameters will be degraded. So once the patient survives stage 3, he will anyway move to stage 4, which is the period of recovery. The NAC, the antidote, which is the antidote protocol, there is one IV protocol, IV 21-hour IV protocol, and an oral 72-hour protocol. Follow it accordingly. If you are not sure about the time of consumption of paracetamol, just check whether the serum paracetamol level is more than 10 micrograms per deciliter. Okay. If the serum paracetamol level is more than 10 micrograms per deciliter, then anyway you will have to start NAC. If you are not sure about when the patient has consumed paracetamol, or in case of staggered dose. Okay. And if the patient fits into any of these King's College criteria, always apply the King's College criteria. If the patient fits into the King's College criteria, then refer the patient to a liver specialist. I hope everything is clear. Thank you.